Breathe, oh breathe, running down all the angels. This could take all night. Think I need a devil to help me get things right. Hook me up a new revolution. This one is alive. Saddle where I'm laughing and watch the last one die. I'm looking to the sky to save me. Looking for a sign of life. Looking for something to help me burn out bright. I'm looking for a complication. Looking for a time of life. Make my way back home and over the fire. Think I'm done nursing patience. It can wait one night. Give it all away if you give me one last try. Live happily ever drop if you just save my life. Wanna tell the angels that everything's alright. I'm looking to the sky to save me. Looking for a sign of life. Looking for something to help me Don't you call him baby. We're not talking lately. Don't you call him what you used to call me. I confess, I can tell that you're at your best. I'm selfish, so I'm hating it. I noticed that there's a piece of you in how I dress. Take it as a compliment. Don't you call him baby. We're not talking lately. Don't you call him what you used to call me. I just miss your accent and your friends. Did you know?
Hi, everyone. I'm just going to give it a few minutes. I don't know what is going on with Zoom today, but clearly something is going on since I've been here since 10:02. Did you guys try using the link that was in the tab? Were you getting an error message? Talk to me so I have information.
There's like 2 links for today's lecture, and it just keeps saying waiting for the host to start the meeting.
Okay. I'll just give it a few minutes and let everybody come in.
Thank you for that email. I was beginning to think that something was wrong.
No, I guess there's, I don't know, the links, there's 2 invites on the Zoom tab, and I went to both, but it's the same room ID, so I'm really not sure why it wasn't connecting, because
Yeah, that's what I was wondering.
so no worries, we'll get started in a few minutes, let everybody trickle in. There should be 40 of us, so hopefully everyone will have gotten that announcement. Just give it a few minutes. At any rate, I'll let everybody trickle in. So welcome. Sorry for the weird get-go this morning. I don't know what's going on. I feel like when everything transitioned from one platform to the other with Ameritech to Joyce, there's just been a lot of little snafus that have been mucking up things. So hopefully we can get that all taken care of. But at any rate, my name is Amy Wisniewski, and I will be your professor for this class. Hopefully you watch the introduction video just to kind of get a feel for the class and the content and the expectations moving forward. So I'm in Milwaukee, Wisconsin-ish, suburb of Milwaukee. I've been at this university for a year now. I've been teaching for 4. My background includes med-surg, transplant nursing, and then the ER, which is my favorite. So I have a very matter-of-fact and blunt sense of humor. So I will try not to offend anyone, but I try to make things more enjoyable because we remember things based off of emotions. And if it's funny, you're more likely to remember it. But yeah, let's see here. So let me answer a couple of emails. Some people not getting in. All right, send those out. So the past few days I've been doing kind of like an introduction. I just want to see your face once, at least once. Tell me your name, and then why don't you tell me the last or your favorite snack food? So anybody who wants to start, I would love for that.
Hi, my name is Philomena Akins. Favorite snack food? I don't really have a favorite snack food, but I love grapes.
Okay.
My name is Asa Gerber. My favorite snack food is popcorn.
I'm a sucker for popcorn and a glass of red wine, I'll tell you that much. Great.
My name's Olivia Roper. I like Cheez-Its probably, or like Goldfish or something.
My name is Sarah Jolly. And my favorite snack food is flavor blasted goldfish.
My name is Erin Berry. I really like beef jerky.
Do you make your own?
Yeah.
Hello, my name is Susan, and I really like to snack on like nuts or cashews, almonds, all that.
Perfect.
My name is Kaya, and I really like cheese and crackers.
My name is Jackie.
Oh, sorry.
No, you're fine. Go ahead.
I was just wondering, what's your favorite cheese? Being from Wisconsin, we really like our cheese here.
I really like Swiss cheese or like sharp cheddar cheese.
Okay.
My name is Jackie Herrera, and I like strawberries.
My name is Will, and I would say like any finger vegetables and hummus, probably my favorite.
Got some healthy nursing students here. Holy moly.
I'm gonna ruin it. I'm Maddie, and my favorite snack food is Red Bull.
My name is Michaela, and my favorite snack food is probably chips with chamoy.
With what?
Chamoy. I don't even know I'm not Mexican, but my boyfriend is, and it's like a red sauce that you put on stuff. It's good.
My name is Erica, and I also like cheese and crackers. Just American cheese and sometimes pieces of ham like the Lunchables. Those are good. I steal them from my daughter.
My name is Sierra Goodman, and I really like dried fruit.
Interesting.
My name's Grace, and my favorite snack is hot Cheetos.
My name is Ala, and my favorite are Oreos.
Ooh. I have a friend who works for Allah, or not for Allah, for Oreos. So he's got the ins on it. All right, give me 1 second. People, I just gotta send these links out. Getting a bunch of emails. Okay, so we're having some issues. Okay, well, hopefully this works. Uh-oh. All right, go ahead. Whoever was next.
My name is Kelsey. I would say my favorite snack would be beef jerky.
Okay.
My name's Haley, and I would have to say pineapple and tahine or pickled beets.
Wow, that's an interesting one. I thought you were just gonna say pickles, and then I'd be like, okay.
Hi, my name is Derek, and my favorite snack is Belvita bars.
I'm Allie.
Oh, sorry.
Oh, sorry.
Go ahead.
And my favorite snack is really just anything sugary. I have a really bad sugar addiction.
Okay, my name is Brittany, and my favorite snack is probably chips and salsa.
My name is Helen, and my favorite snack is peanut butter and apple.
That is a great one. Two of my dog's favorite things too. He goes crazy over apples. I cannot tell you why. Apples and bananas, like drool bubbles everywhere. Who else we got? I know some people just popped in. We're just saying our names and our favorite snack.
Hi, my name is Caitlin, and my favorite snack is probably mango with chili pepper.
My name's Clarissa. Oh, sorry. Just kidding. Go ahead. My name's Clarissa. My favorite snack's probably like Chips Ahoy cookies.
Okay.
All right, I'll go
My
this
name-
time. I'm calling it. I'm going. My name's Erica, and my favorite snack lately has been apple cinnamon rice cakes with peanut butter and honey.
My name is Dan. My favorite snack is just French fries.
All right.
My name is Sam, and I really like chips.
Perfect.
My name is Brandon, and I really like fruit by the foot.
That's one I haven't heard in a while. It's a throwback. Nicole, if you just want to throw it in the chat what your favorite snack is, that'd be great. I know some of you reached out to me, so it's just helping me take attendance. I'll do it a different way next week, but this putting names to faces, it's kind of nice. So that way, you know, I don't have to be like, who are you? Do I know you? That sort of thing.
My name is Maya, and my favorite snack is salt and vinegar chips.
My daughter's favorite. All right, Nicole said Twix. Awesome.
My name is Sierra, and my favorite snack is chips and queso.
My name is Karen. This is tough. I'd probably say anything chocolate.
My name is Alicia, and my favorite snack is granola bars.
Okay. I got 33. Hopefully I didn't miss anyone. So I speak now or forever hold your peace. Oh, I got Danny in the chat. Nicole Alexandra. All right then. Well, thanks for indulging me. Helps me learn a little bit more about you guys as well. So my favorite snack varies from day to day and just kind of depends on my mood. What have I been on a kick on recently? String cheese, one of my favorites. But at any rate, so I just wanted to kind of break down real quick the content in this class, just so there's no confusion. Hopefully I can get the Zoom issue resolved next week since there's duplicates. I think that seems to be the issue. Just so we can get that squared away. So hopefully by now you have taken a look at the syllabus. I don't like to scare people, but I do want to scare you because this is a big course. It is a 6-credit course, and I don't know that you've had a 6-credit course yet in your nursing school journey. So the things that you learn in here get incorporated into clinical and into your SCE as well. So there's a lot of time in this course. There's a lot of things that we go over. So if you look at the grade breakdown for this course, we have 5 unit exams basically, and those are 50% of your grade. They are 50 questions each, worth 100 points. They are given in ATI. There are 4 different times to take the exam. Typically, exams are going to be Monday morning, Monday evening, Tuesday morning, Tuesday evening. That allows us to go over the exams and get grades posted by the weekend. The one exception to those times is exam 1, because exam 1 would fall on Memorial Day. Campus is closed, it's an off day for you, so the exams will be offered on Tuesday and Wednesday. So if you go into your assignments, the times are listed there for you guys. The final exam is a cumulative exam. It is 100 questions, 100 points, and that is worth 25% of your grade. So 75% of your grade in this class are on your exams. Then there are 4 APA style assignments associated with this course that we'll go over. That is 15% of your grades, and then your weekly ATI homework is 10% of your grade. There have been students who miss several assignments and then they don't pass the class. So don't let that be you. Take all your points, just turn things in. I won't hunt you down. If you don't turn something in, I'm not going to say, hey, do you have this? I don't accept late work unless there is like extenuating circumstances like you had a baby or something like that. So plan ahead. Right now, assignment 1 is open for you guys. It's due on Sunday. And then I'm going to post 2 and 3 either today or tomorrow, depending on the schedule for the rest of the day. 2, 3, and 4, actually. So it is in the exams tab in ATI. Take a screenshot of your score and you submit that. If you get 8 out of 10, you can submit 2 NCLEX style questions based off of that week's content and get your full 10 points. The 10 points are always there for you, whether you get all 10 questions right or you need to do some extras just to get it up there. But if you don't submit the extra questions, I grade what's there. I'm not going to trunch you down and say, hey, I didn't have those 2 questions. Do you want them? After Sunday, when I start grading stuff, if it's not there, it's not there. The only time I'm really going to be reaching out to you is if I can't open the document for whatever reason. Sometimes Mac and PCs don't like to talk. I'll be like, hey, can you resubmit this for me? Erica asked, are the questions based on lecture? It's all based on the content that we have. So if you do your reading beforehand because you're a Friday class, you should be okay with answering the questions. Otherwise, potentially after class might be a better bet. It all really depends on your study habits and how comfortable you feel with the content and how you prepare for each class. So I don't have the best answer for you for that because it really depends on you. But the 10 questions are all based on stuff that we're going to go over each week. So we'll try to get the rest of the assignments up by the next few days. We're just switching things over from how they were done last semester to this semester, so it's just taking a little bit longer. A Google Doc is okay, a Word document of some sort. Some people will put a screenshot and their questions all in one document. It really depends on how tech savvy you are. It doesn't matter as long as I have them. The only thing that I ask that you don't do is type your question in the comments in Canvas, because then it just makes it too hard to read. So there are some requirements. The question has to be related to the topic of that week. It has to be multiple choice. You have to show what the correct answer is, because maybe we'll use them for a review, and then include the rationale. So it's a little bit more work than just taking the 10 questions, but the points are there for you should you want them. What else? So weeks 1 through 4 and 6 through 13 will all be an ATI. Week 5 is our EKG week. I have a different assignment for you that we will post week 5, identifying rhythms. And then week 14 is our cumulative review. It is 25 questions. That does not get released until week 14 because there are no makeup points. And I don't want you to try to do them and then you get like 10 out of 25 and then you lose all those 15 points. So the cumulative homework assignment will be released the week of where we're doing our cumulative review. The week before an exam, we will do a review. Those will be posted based off of times that us professors can all conduct the review. And those will be posted and recorded. I put all my recordings on YouTube. It's easier, I feel like it's easier for the students to access a YouTube video than it is a recording in Canvas, because the Canvas on the phone or the iPad is not always the easiest thing to use. So the YouTube has worked really well. So I'll post the recording, hit subscribe. You'll be notified every time a new thing gets posted. And then I'm not clogging up your announcements either with like, here's the recording from this week. So what else? Office hours. Office hours have been posted. I have like 5 or 6 posted. You can do whatever days on there. If it's at a time that you can't meet, shoot me an email and say, hey, professor, I can't meet at those times, but I can meet, and then give me 3 options. 9 times out of 10, I will find something that works for you. Even if I'm on a phone at a baseball game, I'll take the time to sit down with you and talk things over or whatnot. So I don't want you to feel like those are the only times that you can meet with me. I try to be as available as possible and answer things for you guys. So let's see. Briefly, I'll run down the APA assignments. So the APA assignments, it used to be a 10-page paper that we kind of broke down into smaller assignments to help you guys. The first one that's due next Sunday is a reference page. You just have to give an example of a website, a textbook, and a scholarly journal. Incorrect formatting. That's what we're looking at. Do you know how to format? Periods, italics, the right stuff. I don't care where they're from or what they are. We're just looking at formatting. So don't overthink it. Just format things properly. Spacing, hanging indents, that kind of thing. The second assignment is a PowerPoint of a disease. So you're kind of just going over like what it is and how we would care for it. Real brief, 10 slides or so. There's a list of diseases for you guys to choose from. We don't want you spending time focusing on a disease that we're not going to test you on or work on in this class. So don't be like, I want to do sickle cell anemia, because we don't do sickle cell anemia this semester. Let's spend our time focusing on stuff that we need for this class. So there's like 10 diseases. If there's something else that's not listed and it's related to something that we would talk about in here, shoot me an email and I can say yes or no. But really, I want you guys to use your time in the most beneficial manner. So getting a heads up on hypertension makes a lot more sense than something we don't even cover in this course. So I had some really nice ones last semester. It's just helpful. Nothing terrible. And then the third one is my favorite. It's the culture assignment. You guys are going to do a presentation for me. You record yourself teaching me something about one of the listed cultures. So there's like 6 or 7 listed, and you choose one and you go through the rubric and explain what this culture is, how their beliefs affect their care, diet, gender issues. You'll notice that the list of populations, Hispanic and African Americans are not on that list. I want you to explore a different culture that you may not be at all familiar with to help make you be more culturally competent. So, you know, the big 3 races that we see or cultures that we see in America are white, Hispanic, and African American. I want you to expand past that. So you can do a Zoom recording like this and upload that. You can do a voice over PowerPoint. If you really want to, you can do another paper, but it's helpful for you guys to learn how to teach, because nurses teach their patients and we have to get good with communicating. So, and then the last assignment is a paper on the nursing process. There's a little scenario and you just go through the nursing process and how you would care for this patient. And then I'll post a template in a few weeks for you guys to utilize to help with that. So those are it. Questions?
What times are, like what exact times are the exams for ATI?
With the exception of exam 1, I'm going to talk about 2, 3, 4, and 5. Mondays at 10 a.m., Mondays at 6 p.m., Tuesdays at 8 a.m., Tuesdays at 6 p.m. And then exam 1 will be that Tuesday and Wednesday with those same times. So 10, 6, 8, or 6.
I think it's posted somewhere. I read it.
Yeah, they're in the in the
Where?
assignment where the exam is, the time is listed for each one. So
will you be so on the modules for the lecture where we have the PowerPoint that you listed, it just keeps saying fail every time I try to download it. Can you repost that by chance?
the announcements.
Oh, it is. Oh, thanks.
Yep. For whatever reason, it's only week 1 that's giving us all these issues with the PowerPoints. All the other ones work, but except for week 1. So if it says to request access, I can give you access real quick too. So in the modules, there are recordings listed. Dr. Greg did some voiceovers. They are not required. They're an additional resource that you can use. They're quite long, so it truly depends on your time and what you want. They're more science-based, so they may be helpful if you need a patho review. It's not that I don't, because I truly do, but because they are so common, I want you to learn about something that you may not already know about. Does that make sense? Okay. We can discuss that later. Any other questions? All right, then. Let me get this set up for you guys then, and we will hit the ground running. Oops. All right, so I'm also going to preface this. Your textbook, the Hinkle Achiever, you guys are blessed with a digital copy. The actual textbook is about this big. It's huge. And there are times where the words are just incredibly overwhelming. Like it's too much. However, there's a lot of important content in there. So it should be part of your study habits, looking over, solidifying topics. ATI is great. It really breaks things down in a very condensed manner, but sometimes it's truly not enough. So make sure that you're utilizing both of those resources in terms of your reading. So that being said, my first question to you guys is, what parts of the body make up the upper airway?
The nose, throat, esophagus. No, trachea, not esophagus.
Okay. Anything else we're missing?
The pharynx, right? The nasopharynx, oropharynx.
Yep. So our upper airway consists of our nose, our paranasal sinuses, our pharynx, our tonsils and adenoids, if you still have them, and then the larynx and the trachea. So the respiratory function, really its job is one thing broken down into pieces. We need air to breathe. Our cells need oxygen. If we are not breathing, we are not living, okay? So the respiratory system's main job is to transport oxygen to the rest of the body. Then we also have respiration, ventilation, and diffusion and perfusion. All things that happen that we don't think about, but it's essential to life, okay? So with oxygen transport, this is where diffusion happens, okay? Oxygen is going to go to the cells. It's going to take CO2 away, and this is all done via the capillaries. Basic stuff here. Not going to dive too much deeper into that because you've had the deeper stuff already. You just have to understand that where this happens. Respiration is the gas exchange. This is between air and blood in the cells. So lots of stuff is going on back and forth. Deoxygenated blood is going to come from the heart and the lungs and then go to the rest of the body. This, again, is between the air that you breathe and the blood, and then the blood in the cells of the body. And everything moves in concentration gradients from high to low. Everything is going to adjust itself. That is it. So you have to understand the term respiration is actually gas exchange. Ventilation is the movement. So when we count respirations, we're actually counting ventilations, okay? This is where we take our breaths. The diaphragm is going to contract. Our chest will expand when we take a deep breath. When you take a deep breath in, your chest expands, your diaphragm moves down, and then when you exhale, it shrinks back. The diaphragm will move back up, and everything will move back into place. Inhaling requires energy. Exhaling does not. But people that have respiratory disorders, they expend a lot more energy to breathe, which means they get tired more quickly. If you've ever seen somebody having an asthma attack or having issues with COPD, they're working so hard to inhale, they get tired really quickly. So again, ventilation is the movement. Respiration is the gas exchange. With the ventilation, again, air is going to go from high to low pressure, always. It just follows the same little path that it always does. Again, the thoracic cavity is going to expand, the diaphragm moves down, and then it comes back up and the cavity reduces itself. Airway resistance means air cannot get through. Okay, so this can happen due to medical conditions like asthma. If the airway narrows, it requires more energy to get the air through versus a nice open airway. So we don't, these are things that the airway resistance we want to prevent from happening. And if it is occurring, find ways to open up said airway. Compliance sounds like it's a good thing. Compliance in and of itself is fine. That is telling us how well the lungs are really working. So increased compliance, that sounds like it'd be really good. Like our lungs are super awesome, they're really working. But it's not. Increased compliance is a bad thing. It means that our lungs can't recoil. They've gotten too big. They are stretched out. This is most commonly occurring with COPD and emphysema. So it's kind of like when you take a balloon and you blow it up and then you deflate it. The balloon isn't going to go back to that normal size anymore. It's been stretched out so far. So it's kind of flippity floppity. It's the same premise. So we don't want increased compliance. Decreased compliance is also bad. The lungs become real stiff and hardened and require a greater effort to breathe. We see this a lot with our morbid obese patients and anybody with like a hemothorax. Basically, the lungs can't do what they're supposed to do because they're trying to work through either blood and fluid or fatty adipose tissue. So increased compliance and decreased compliance are no bueno. We don't want them. Okay. In your book, there's a lot of pictures and a lot of charts. And I don't want you to get too caught up in them on the ones between 485 and 488. Looking at those pages, your head might start to spin, okay? That's a nice to know. You can take a look at it, but I don't want you to focus on that up until where it starts talking about assessment. If you need a patho review, then it's awesome, okay? All right, time for our first polling question. All right, I got about 92% who answered, so I'm going to go ahead and wrap this up. So increased compliance of the lungs means that the lungs are stretched out. Lungs requiring a lot of energy to expand is going to be the decreased compliance. The lungs can expand with increased compliance, but they can't shrink back down. They lost that ability to recoil. And increased compliance do not work better than normal. They work worse. So, all right, awesome. Diffusion and perfusion. So with diffusion, we have movement of gas from high to low concentration. Doesn't matter what kind of gas, that's what diffusion means. With pulmonary diffusion, this is where oxygen and CO2 are going to exchange from high to low. And then we have tissue diffusion, which the same thing. is going to happen there. One happens in the pulmonary vasculature, one happens in the tissue. That's it. In terms of perfusion, this is blood moving through the body. We know all about perfusion by now. Our heart perfuses blood to the rest of the body. That's how our cells are alive and our body functions. So with pulmonary perfusion, this is the blood flow through the vasculature, and tissue is getting blood to the rest of the tissues. Perfusion is important because if we don't have blood flow, what happens?
Cell death.
The stuff is going to die. It's going to become ischemic and it's going to die. So perfusion is incredibly important. They work together. Diffusion is going to move the gases. Perfusion is going to get the blood to where it needs to go. And if we don't have the perfusion, we have bigger issues. All right. Nice little review for you guys. Let's get into the nitty-gritty. So when we're doing a respiratory assessment, it's not just busting out your stethoscope and listening to lung sounds. We have to have a good understanding of what's going on with the patient, what do their symptoms entail, and then their past health history. So in regards to the respiratory system, we need to know what symptoms they're having, okay? Are you having shortness of breath? We use the term dyspnea. Your patients will not know the term dyspnea unless they work in the medical field. So remember not to, we document using the right terms, but when we're talking to patients, are you having any shortness of breath? If they respond yes, what are some of the questions that you would ask your patient?
Like, how long has it been going on?
Absolutely. History.
There's
Yep.
any pain?
Okay.
You could ask about like aggravating factors and like relieving factors.
Yep, 100%. What were you doing when this started? Okay. Other things that we want to ask about is a cough. Do you have a cough associated with this? And cough is a scary word these days because we all think cough and we're all jumping to COVID, but it is important to know, do you have a cough? And then, are you expectorating anything? That's one of my favorite words. Are you coughing anything up? We can tell a lot by people's bodily fluids. If they're coughing up green gook, infectious in nature. If it's clear, probably just some standard mucus, maybe from allergies or who knows what. But again, we can tell a lot. Finding out if there's chest pain associated with what's going on or any type of blood. One of the most important things that we have to ask with respiratory assessments is if they're having any difficulty swallowing. Why would I care if they can swallow?
You have to make sure that they don't have like an obstruction of some kind that's causing them to not be able to breathe correctly.
They're at risk for aspiration.
Yes, they are at risk for aspiration. If they aspirate, they can get pneumonia. If they get the pneumonia, they can die. Yes, I know that's worst case scenario, but it is a very common circumstance, especially as you get older and things take longer to heal and recover. So if we are concerned about anybody swallowing, please do not let them put anything in their mouth. They need to be NPO. Until they get cleared by a swallow study, not going to happen. That is a huge safety concern. In terms of their health history, their social history, and their family history, what are some concerning questions that you would want to know to help dictate your plan of care or what's going on?
Do you smoke?
Do you smoke? Let's discuss this for a second. So we can ask if they smoke. Where else do we need to go with this?
Members inside of their household smoke.
Does anybody in your household smoke? How much do you smoke? What else?
Asthma, allergies, any history of family respiratory issues?
Okay.
What are they smoking?
What do you mean, what are they smoking?
like how some people do like the vapes or like their cigarettes, or some people smoke like marijuana, or some people do like crazy
Meth?
cleaners.
Absolutely. You are 100% correct. We tend to stop smoking and just think that it's cigarettes, but everything has expounded so much, and we have to know. I always tell my patients, I don't care if you smoke crack. I don't. I mean, I do, but I don't. I'm not going to call the cops, but I need to know what you're doing so I don't kill you, right? I'm not narking to anybody, but if I know what you're smoking or what you're inhaling, it can totally dictate the plan of care, because we know certain things will interact with other things. So being as non-judgmental as possible, but also knowing that smoking isn't just cigarettes. Vapes are incredibly dangerous, and they're not regulated by the FDA, and they can be filled with God knows what, especially ones that you get at the gas station. Like, who knows what they are. So digging into that. All right, so we're talking about smoking. We talked about allergies. What else do we want to know?
Maybe if multiple sclerosis runs in their family, or if they've been testing for it.
Okay, so their health history, family history with that. What other stuff about their life that could affect their respiratory system?
What their occupation is.
Absolutely. Why do I care what their job is?
They could be exposed to certain things that are affecting their lungs.
100%. I think we always think like coal miners, especially like they inhale a lot of stuff. Painters, dry cleaners inhale an insane amount of fumes. So we have to know what their job is, because if they work in stuff with like asbestos or anything like that, it can directly impact their respiratory system as well. So knowing what their job is, also where they live. Not everybody lives in a nice picturesque, like crystal clean water, air, forest or whatnot. They could live in a bigger city where there's a lot of pollution and a lot of irritants that can trigger respiratory issues. Anything else that you can think of?
Maybe like cardiovascular history because of like risk of an embolus or something.
Recent travel, recent surgeries.
What their activity level is.
Absolutely. All important stuff. Okay. Physical assessment wise, there are some things that we can do. We need to look before we listen or do anything else. We walk into the room, you get your first impression right there, their general appearance. What is going on with them? Are they working hard to breathe? Are they in respiratory distress? Does it seem like they're uncomfortable? We can see these things. Are they blue? Is there cyanosis going on? Clubbing of the fingernails is something that we can see with our COPD patients. It's a finding of that. The fingers become real kind of chunky at the fingertips, basically real rounded. This isn't something that happens overnight. It's years and years of respiratory compromise that has caused this. But if you saw that on somebody, you could know then, oh, hey, they probably have COPD. Let's take that into consideration. In terms of other assessments with the respiratory system, observe. We want to look at the mouth and the nose and the throat. Is there anything obstructing there? I'm going to tell you, it is not just kids that stick stuff up their nose and in their mouth and where it doesn't belong. Plenty of adults will be like, here, hold my beer, and they try to get something to fit where it shouldn't go. So if there's a foreign object, that can cause issues with their respiratory status as well. So taking a look at that stuff. In terms of assessing visually with the lower respiratory assessment, we're looking to see how well that they are breathing. What position are they in? Tripoding is a very common position when people are trying to work to breathe. That shows me they're having breathing issues if they're in this position. Okay, so if they're leaning forward, trying to work to breathe. Looking at their chest. Intercostal retractions and usage of accessory muscles are not a good thing. Maybe they can't talk to you, but if I see them working to breathe, they are in respiratory distress. I need to take action. Then we listen. What do I hear? And then we can move on. With breath sounds, you guys have had breath sounds, you've heard things. Breath sounds are one of those things you just have to keep listening to get better at them. The more you listen, the more comfortable you get. Every breath sound is associated with something going on in the lungs. When we hear wheezing, we have a narrowing of the airway. The most common time we have wheezing is going to be with an asthma attack. Everything is constricting, they can't move. You have to understand wheezes is associated with a narrow airway, okay? Crackles means, especially coarse crackles, means that there is fluid in the lungs, whether it's from pneumonia or pleural fluid. We shouldn't hear the crackles when they inhale or exhale, okay? It sounds like Rice Krispies. It means there's fluid. Fine crackles, we typically hear with like scarring in the lungs. So they've had a history of pulmonary issues, and it's a lot more subtle. I'm going to tell you as a practitioner, when you're trying to figure out, are these fine crackles versus coarse crackles? Crackles in general is completely appropriate. Sometimes it's really hard to discern, and we have to leave it to the pulmonologist or the respiratory therapists. But coarse crackles mean fluid. Wheezes, narrowed airway. Rhonchi are that low grumbling noise, and usually that has to do with secretions built up as well. If I hear crackles or even rhonchi, what is one thing that I can do right there?
Sit them up.
Okay.
Have them cough.
Have them cough and then re-listen. Sometimes just coughing is enough to clear those crackles, and that's why we encourage cough and deep breathing. Okay. So this chart was in your book. This is a good one to have in on hand. All right, I'm gonna pop this up here, and just a reminder of your breath sounds because they're important.
Inflammation, low-grade inflammation is
talking. I hate YouTube ads.
James, I'm now going to listen to the chest. If you could just take some deep breaths in and out through your mouth.
Okay, so just a little reminder of how things kind of sound for you. Okay, so let's go ahead and do another polling question. All righty, coarse crackles, they would indicate fluid in the lungs. Remember, narrowing of the airway is going to be our wheezes. Upper airway obstruction, what would that be?
Stridor.
Stridor, which I swear is the scariest noise I've ever heard as a nurse, or even as a mom. Okay, and then scarring of the lungs, that's going to be your fine crackles. So, good job. Ooh, holy voice crack. All right. We are at 11:58. This is a good time to take our first break. I break every hour-ish, so we get 2 breaks in the class, just so you guys are aware. I really like even numbers, so we're gonna come back at 11:10. All right. I grew up overnight. I played alone, I played on my own. I survived. Yeah, I wanted everything I never had. Like the love that comes without. I was empty and I hated that, but I survived. I don't want it to be too much for the demons go. But the wind don't change, the lift in the ground can never go. No, just lies, me talk to cry in your pillow. I survive. I'm still breathing. I'm still breathing. I'm still breathing. I'm still breathing. I found solace in the strangest place, way in the back of my mind. I saw my life in a stranger's face, and it was mine. I don't want it to be too much while the demons go. But the wind don't change, nothing in the ground can ever go. No, just lies, no time to cry in your pillow. I survive. I'm still breathing. 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 Every single mistake I took, never probably made. I took and I took and I took what you gave, but you never noticed that I was in vain. I knew what I wanted, I went and I got it. Did all the things that you said that I wouldn't. I told you that I wouldn't, but we forgot it, and I inspired you. I'm still breathing. I'm still breathing. I'm still breathing. I'm still breathing. I'm alive. I'm right, let's bring it on back here. And we can continue on with our content. How are we feeling so far? Nice little review? Nothing too crazy, nothing that wants to make you cry yet, right?
Not
All
yet,
right.
but it's sure to happen at some point.
I mean, is it really nursing school if you don't cry at least like 5 times a semester? I don't know. I get it. Okay, let me pull this stuff back up here and we will continue on. All right. Okay, our diagnostics. So, keeping along with ADPI, we do certain things to help diagnose certain respiratory disorders. Some are more invasive than others, and some are really basic that we just totally are like, well, duh. We do that, don't we? So one of the easiest, the most non-invasive, the most basic of things that we do that is technically a respiratory assessment is a pulse ox. This measures the oxygen saturation of hemoglobin in the blood. Easy peasy, right? It's part of our vital signs, but it gives us an immediate action as to like, hey, what's going on with you? There are times though where we don't get the right numbers, and that can be because of massive blood loss, like through a trauma, because there's not enough blood, aka, and then there's not enough hemoglobin to circulate and to gather that data, or with carbon monoxide poisoning. If there is a suspicion of carbon monoxide, we're not going to get a good O2 level. And then we have a poor pleth, which if you've ever done a pulse ox, a little wiggly line comes up. Those peaks and valleys tell us that we're getting good breaths. And if it's not really moving, then we're not capturing a good pleth. And usually that has to do with poor circulation, or something interfering, like certain colored nail polishes or things along those lines. So we just want to watch out for that. Side note, future nurses, it is an O2 stat, not an O2 stat. Just throwing that out there. It's O2 saturation, okay? Nothing drives most nurses crazy than hearing O2 stat. These can be placed anywhere. Most commonly is going to be on the finger or the toe. If you're having a hard time on a finger, the toe may not be the best bet because fight or flight, blood goes to our core and the toes are not important. So it might be a little bit more difficult. The earlobe is probably the second most common place and probably the easiest to gather. And that's what this little guy is here. That's an ear probe. If you can find one, great. These ones can be used on neonates or adults. So with babies, we tend to wrap it around their feet, but we can also use these if we need continuous pulse ox monitoring around the finger. The bad side to these is that they're single use or single patient, so these are expensive. Cost-wise, this isn't something we want to always just like jump to, but if they need to be hooked up for a long period of time, it's easier to stay on than the big fat plastic piece. And then we have ones that we can put over the nose and the forehead, which I have not seen as much, but we get creative. All righty. So most non-invasive diagnostic we have. Quick question. Let's hear what you got. You're starting your shift, you go in and your patient's pulse ox is 88%. What are you doing first? And I know there's not a lot of information here, but we're going to have some dialogue.
Sit them up and probably get a nasal cannula ready just in case.
Okay.
I'd say check the positioning of the pulse ox.
You want to check to make sure that it's on? Okay.
Ask the patient if they have COPD.
Why would I care if they have COPD?
Because they usually have a lower sat.
Mm-hmm. Anything else? So there's not a lot of information here, but I'm going to tell you first, let's double check our findings. Treat the patient, not the monitor. Okay, so is their probe on correctly? Because that might be why it's 88%. If it's on properly and it's still 88%, positioning is important, knowing their baseline. Like we mentioned, they might live at 88%. We really don't have any information to know otherwise. So if we were to give somebody with COPD a whole bunch of oxygen, we can actually make them worse if they're CO2 retainers and then they can't blow that off. So we have to, again, look at the patient monitor and gather more data. The moral of the story is, like, let's not freak out right away. Let's gather some more assessment findings and figure things out. So good. All right. We're gonna do more pursed lip breathing exercises in a minute. Pulmonary function tests. So I'm going to hopefully ease your fears a little bit. So looking at, okay, pulmonary function test tells us how well our lungs are working. It helps us figure out if there's some type of lung disease or lung issue, and gives us a baseline. In terms of what nurses need to know, it's pretty much what they are and how they're done and how do we have to prepare for them. These are what PFTs look like, okay? There are graphs. There's a lot of letters and a lot of initials that are way above your pay grade. So looking at this, you're probably like, crap. I don't want you to get hung up on this. This is a visual, so you know what it looks like. In terms of PFTs, you need to know this. They help identify lung disease. We don't smoke 6 to 8 hours before PFTs are going to be taken, and we don't use an inhaler 4 to 6 hours beforehand. But patients need inhalers to breathe. So why would I not want an inhaler to be used before a PFT?
So you can actually get an accurate reading on their baseline and not when they're medicated.
Exactly. We want to know where they're at without the medication. So no inhalers, no smoking. There are some key terms that are important for you to know in terms of respiratory assessments, and that is one of them is tidal volume. So tidal volume is how much air you are inhaling and exhaling with every breath. That's what the PFTs are partially going to figure out. And then the vital capacity is a formula that you calculate the maximum that you breathe in and out. So don't get too caught up on that. We use PFTs to determine our baseline, identify lung disorder. We do them if we're concerned about a respiratory disease or before surgery, like a big one where they're going to be intubated for a long period of time, because we need to know where they need to get back to. So it provides a baseline. They're non-invasive-ish. They require a lot of breathing. So compared to a pulse ox, they actually have to work, because remember, inhaling requires energy, whereas a pulse ox, they don't do anything. So, but it is a very, very important piece, especially with patients with COPD and asthma. All right. ABGs. I bet you guys wish you were done with these. I know you had a great experience with them last semester. So an ABG is the most accurate diagnostic we have for oxygen level in the blood. It's the best. However, it's pretty invasive. Yes, Erica, 6 to 8 hours. And then no inhalers, 4 to 6. So with ABGs, it tells us the acid base, it tells us oxygen, CO2, bicarb. A whole lot of information comes from this, okay? It even gives us electrolyte values if we wanted it to. In this course, particularly in this unit, it's a respiratory unit, guys. I think it's safe to say that if we're figuring out an ABG, it's probably going to be respiratory related. We also don't dive into compensated, partially compensated, all that kind of stuff. Respiratory acidosis, alkalosis, metabolic. That's what we care about. So with the ABGs, it is important for you to understand what causes can cause respiratory acidosis. Respiratory acidosis we see with things like drugs, inability to breathe well, COPD, even some pneumonia. So respiratory acidosis, we're going to have a low pH, a high CO2, and a normal bicarb. With respiratory alkalosis, we see that with our hyperventilating. So when someone who's not breathing well. So we're going to have a high pH, a low CO2, and also a normal bicarb. So I want you to be able to identify causes of respiratory acidosis and be able to recognize what lab values would go along with that. So if someone had a pH of 7.7, a CO2 of 34, and a bicarb of 25, what condition is that?
Respiratory acidosis.
I have a pH of
Respiratory
7.7.
alkalosis.
Yep. So being able to identify, okay, this is respiratory acidosis or alkalosis. And then what are common causes? Okay, common causes are big here because that's now we're learning how to care for them, right? In terms of ABGs, who can collect them?
Respiratory.
Respiratory therapists.
And specially trained nurses can as well if they're like qualified to do so.
Yeah, it's within a nurse's scope of practice. I did them all the time in the ER. I enjoy them. Yep, or a provider.
Anesthesia.
Yep. So again, ABGs are your most accurate respiratory assessment. They help us diagnose things with the respiratory system, our electrolytes, our kidneys, anything that we are concerned about. It also helps us monitor how well what we're doing is working. In terms of somebody who's on high dose oxygen therapy or intubated, we can collect multiple ABGs to see if we're doing okay, or if we're improving, or if we're trying to get them off of a ventilator. So if they require frequent ABGs, they'll put something in called an ART line, an arterial line, which is basically like an IV that goes right into the artery and will allow us to pull blood off without poking them over and over again. So with an ABG, has anybody helped collected one or seen one done?
I have, but only from the umbilical cord in LB.
Okay. Anyone else?
I do it at my job.
Okay. So
I saw a respiratory therapist do it in the ICU.
okay. And what did they do? What is done?
I think he takes the blood and then he runs it to the lab or something. I don't remember. I just remember he took blood.
Okay. So where are we taking the blood from?
Either an art line or an artery.
Okay. And how do I know the difference between an artery and a vein?
It pulsates.
And I don't mean that as a dumb question, but it's true. Arteries pulse. So that's how we know where we're in the right spot. So we find the pulse, we clean it, and then we stab it with a pretty big needle. This isn't something that it hurts more than an IV, but it's not like open surgery with no anesthesia, right? So it's not pleasant, but it's quick. They withdraw the blood, they hold pressure for a good 60 seconds or more, and then they go about their way. There are venous blood gases where we would pull from a vein. The numbers are going to be different though, and it's a little bit of a, they got to do some stuff to kind of connect it, but they can tell if the blood is actually from an artery or a vein here. So if your patient says to you, why do I need this? Your best response would be ... What would you say?
We need to collect oxygenated blood before it reaches your like tissues.
Okay.
It gives
In
us
order-
a better overall picture of their respiratory stuff going on.
Yeah. Most in-depth, most detailed. It gives us all of, it's a big piece of the puzzle. So we have to just say things like it's the best, the most accurate, that sort of thing. So if we're educating our client on the ABG, that's what they need to know. And we can walk through the procedure as well. Tests come back pretty quickly with these. The big, bad, scary things, because we are doomsday people. Okay, if you weren't, you should be. We always have to think about worst case scenario. What we're doing could cause what? An ABG, the real big complication is going to be a hematoma. We're not going to kill you. We're not going to rupture the artery, nothing like that. Maybe a little bit of bleeding, but we're going to hold pressure. But a hematoma is pretty much the worst thing that can happen. So, questions on ABGs? All right, well then I have a question. And let me pull it up for you. Oops. Okie dokie. So, hypoxemia. First and foremost, what is hypoxemia?
A low amount of oxygen in the blood.
Okay. So once we know what that word means, which one of these labs will tell us about oxygen? And that's going to be our PaO2. So the PaO2 of 65 is telling us, hey, we got hypoxemia going on. Okay. Our pH is going to tell us about our acid. The CO2 is going to tell us about the carbon dioxide, and CO3 is our bicarb. So oxygen level of 65. Not a lot of stuff makes me go, ooh, but that one, that definitely would. Okay. So the next diagnostic is a bronchoscopy. This is one of my favorites, okay? This test is so versatile and does so many things. So what it is a flexible or rigid tube that goes down through the mouth, down the throat, and lets us really see. We can see the larynx, the bronchus, the trachea, what's going on. Not only does it let us see, but it can grab tissue for biopsy. It can help remove secretions in our people that can't get stuff up. It can remove foreign bodies. So our people that swallow things, they will have a bronchoscopy done because we can help remove it. So it has a lot of uses. This is awesome. With the bronchoscopy, again, there's two kinds. The fiber optic, which is a more pliable, movable tube and then a rigid bronchoscopy. They'd have to have their neck back, and it's just a straight, like almost like think of it like a pen going down. But they do the same thing. Flexible is a little bit easier to do. Bronchoscopies receive pain medication and sedation, a little bit of conscious sedation. Fentanyl, a little milk of amnesia, aka propofol, to help get them through this. Knowing that they are receiving pain medications and anesthesia, what assessments or what concerns do you have?
Respiratory, like the respiratory rate. We want to know if they're having respiratory depression.
Okay. Anything else?
Oh, go on, Will. You're good.
Oh, I was gonna say, aspiration.
What about it?
If they're under anesthesia, they're not going to be able to use their gag reflex.
So one of the first things that you should assess after this is all done
Is if they can swallow.
Yeah, we got to test their gag reflex. That is a huge safety concern. Guys, we test you not so much about ABs, like identifying like what is a bronchoscopy. That may be in there in a sense, but we want to know, do you know the safety? Do you know the teaching? Do you know what to look for? We want you to be safe. So if they are receiving anesthesia, no matter what they're having done, can they swallow? Can they breathe? These are things that we're really looking for. So with bronchoscopies, there are some big, bad, scary things that can happen. One of them being an allergy, usually to either the anesthesia or the medications that they're having, okay? It's not so much the material or what's going on, but the medicine that we're giving them. So we'd assess for that. Oversedation is another potential complication of a bronchoscopy. You know, if they're opiate naive, 50 mics of fentanyl might not do much for you or I, but for somebody who's more opiate naive or a little bit like, we don't know, they could be snowed for hours. Well, not hours because it has a fast metabolism, but you know what I mean. Oversedation is something that we'd look for. Are they difficult to arouse? Are their oxygen levels okay? Are they taking shallow breaths or only having a few breaths per minute? These are things that we'd have to look for. Infection is another potential complication. Especially for biopsying, we're entering a crevice, okay? We're going into the body, we're pulling stuff out or taking a look around. Infection is obviously a concern. And then that aspiration. Patients can choke on the secretions, or we advance that diet without confirming their gag reflex. That's a big issue. Laryngeal or bronchospasms are another potential complication that can happen. You guys have had like a Charlie horse in your life, right? You get a cramp in your leg and they're awful. That's what a bronchospasm is. Your bronchus is PO'd that something is tickling it and digging it around, and it's like, nope, 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 don't like that. But it can make it difficult for someone to breathe. So it's just muscle contractions that really can screw up the breathing and constrict the airway. So we have to make sure that they can breathe appropriately.
So
go ahead.
Sorry, I was just gonna say I seen one of these performed last semester in endo, and it was freaking crazy. Like just the ability that they have to, like the anesthesiologist to like put them to sleep, and then if like their rest, like everything's too low to like medication to bring them back up. Like it was wild.
I'm glad you got to see that. Like I said, this is one of my favorite things because it does so much. A pneumothorax, which is puncturing and collapsing the lung, is also a potential complication. Truly, it depends on where they're going and what they're taking a look at. And then bleeding, especially if they have a history of esophageal varices or trauma or anything like that, bleeding can occur, or if they're biopsying. So these are really great images of what a bronchoscopy looks like. So this first one, you can see this is going down the throat. This is where it bifurcates into the bronchus, and then we have the cartilaginous rings. This is what we should see. This one, we got some bleeding here, or a mass, so that would need to be removed. And then we got, this looks like mucus, like some grossness that would need to be removed. But that bronchoscopy can help get that done. So very versatile a test that we have here.
I have a quick question. When a patient like experiences like a bronchospasm, do they do anything for it or do they just wait for it to stop?
We oxygenate them as much as possible, and then maybe like a muscle relaxer to try to help calm the muscle down. But the main thing is really getting them oxygenating. And in severe cases, it may require intubation.
Thank you.
All right, the thoracentesis. So this one is a little bit different. This is where we are taking fluid that's accumulated in the pleural space. So that pleural lining that we have, it is built up with fluid. It could be blood, it could be pleural fluid, it could be pus. We're gonna get it out. What happens is if that pleural fluid, whatever's in that pleural space gets too big, the lung can't expand as much as it needs to, so we have poor breathing going on. So let's get that fluid out so our patient can breathe. This is usually done in an emergency because we have to drain it pretty quickly. The patient is usually awake for this. They'll get a little bit of numbing fluid, they'll put in a big needle, and they'll aspirate this fluid. The key to a thoracentesis is to keep the patient still. We don't want them talking or coughing. I know we want to keep them calm, but when we talk, we move and there's vibrations, and we don't want them to poke something they're not supposed to. So they can take up to 1 liter of fluid off of this. And then afterwards, they get like a 2x2 and some tape over it. But the big, bad, scary things that can happen with a thoracentesis is going to be attention pneumo, which would cause this mediastinal shift. So we're going to see stuff go where it's not supposed to. Collapsing of the lung altogether because we poke too much, bleeding or infection. Guys, anytime we cut the skin in any way, shape, or form, even if it's for a needle poke, we're at risk for infection. So, why would they do this over a chest tube? It truly depends on how much they need to pull off. Is it something that they're expecting to just resolve, or is it something that's going to need continuous drainage? But this is something that they can do very quickly at the bedside to remove a whole lot of, like 1 liter of stuff, which is a lot of fluid. Questions on thorax? Alrighty. Cultures. I feel like you guys are well versed in cultures. You've all been cultured, I'm guessing, because you've had a COVID swab, right? Respiratory cultures, we can do either the throat, the nose, or the nasopharyngeal area. What's a big throat culture we do?
Strep.
For strep. I would jump out on a limb that probably 90% of us have been swabbed for strep at some point in our life. What's important to know about cultures is that you have to know what you're swabbing and for why, but we have to get the culture before we're administering antibiotics, okay? No matter what kind of culture, it could be a wound, it could be urine, it could be stool, it could be the nose. We are not giving antibiotics until we get that information that we need. Once we swab, go nuts and start that stuff, but we need that initial swab before we do anything. Antibiotics can start to knock things out and we don't get a true representation of what we need. So lots of different swabs here. This red one is very commonly used for strep. However, depending on the facility and what you got going on, it might be a different color. So don't get too caught up in colors and things like that, because depending on where you are, it might differ. So if you need to do a swab, you can usually contact the lab and say, hey, what swab do I need? And they'll tell you, or they'll have like an online reference guide for you to access. Because some go into liquids, some go into just like this solid medium, and go from there. Alrighty. Oh, I missed it. You guys have all been swabbed for COVID, I'm assuming at some point, right? What's like your instinct when they come at you?
Pull the head away.
Like to move or to swat. Whenever I do anything with the nose, I have my patients sit on their hands, so they're less likely to swat at me when I'm picking their brain. So just throwing that out there as a little trick of the trade. Sit on their hands so they can't, because they'll swing at you. I always tell them I hit back. Okay, our sputum studies. For whatever reason, guys, sputum cultures are one of the hardest cultures for us to grab. I don't know why, but patients don't want to expectorate for us. So sputum samples tell us, is what they're coughing up infectious in nature? And also, depending on what we're trying to grab, can help us identify certain forms of cancer and malignant cells. It is important that with sputum cultures, we're getting sputum and not spit. I don't want your little bubbles. I want the loogie. I want that deep down cough, gross thickness in that cup. So the best time to collect a sputum sample is going to be first thing in the morning before they've had anything to eat or drink. Think about how you feel when you wake up. You're usually like, you cough, right? Everything settles when you're sleeping. Everything relaxes. Now we got to get it all out. So sputum samples in the morning. It goes into a sterile container, just like a urine sample, date, time, initial, all that good stuff. This is, again, most commonly used to diagnose certain forms of pneumonia and things along that line. If we really need it and they're not giving it to us, worst case scenario, they could do some type of invasive thing like a bronch, but they're going to do other stuff when they're there. They're not just going to sedate you and grab sputum for the heck of it. But again, the biggest complication you're going to see is you send the sputum sample to the lab, excuse me, and the results will say normal oral flora, which means we just got those little spit bubbles. We didn't get the good stuff, and then we have to recollect it. So, all righty. Some of the imaging. Chest X-ray. Chest X-ray is one of the most common diagnostics, or an X-ray in general. It tells us a lot. It makes us look at the bones. We can see what's going on. It is contraindicated in pregnancy unless the benefits outweigh the risk, and we really need to. We'll shield them, okay? With a chest X-ray, it helps us diagnose blood, collapsed lungs, pneumonia, broken ribs. But what they need to do is they need to take a deep breath and hold it. Why are they taking a deep breath? Because the lungs are expanding and we get the best image of what's going on. So they take a deep breath and they hold it, they snap their picture, we're done. X-rays can be taken standing, sitting, or laying down. Standing really gives us the best view and it allows for the most lung expansion versus sitting down or even laying down. The important things with chest X-rays, no jewelry, no metal. Let's take off the necklaces, take out the piercings. All of it has to go because it can affect what you see on your image. You might have looked at some chest X-rays and patients' charts and you can see their EKG electrodes even. Technically, we don't want any of that. We want to see the lungs, not everything else. If they are getting X-ray, it is important that we are concerned about radiation exposure, not just for the patient, but for the nurse. So anything that doesn't need to be imaged, let's cover it, okay? You as a provider, if you're there with the patient, wear your lead apron. Protect your baby-making parts. We want to protect the ovaries, the testicles, the uterus, and the thyroid, which isn't a baby-making part, but it's susceptible to damage. That's why we wear that thyroid. There's like a little neck thing around it. We have to be very concerned about the amount of time that we're exposed to this, how close we are to it, and making sure that we stay covered. And if the patient doesn't need certain things, we cover that as much as possible. We want to prevent injury, okay? even if you had a hysterectomy or a vasectomy, we still cover those parts, okay? All right. CT scans. This is my favorite. Quick, detailed imaging of pretty much any body part, okay? We're talking more respiratory wise, so it's going to be more of our chest. It can help us diagnose pneumonia, bleeds, PEs, anything along those lines. A CT scan also has some radiation, but not terrible amounts. We want them, the biggest thing that they have to do is lay still, which can be difficult. They have to lay on their back and they have to lay still. But the whole scan does not take that long. So at least, you know, if they can get through 90 seconds, we're good to go. We tend to avoid CT scans with pregnancy just to minimize effects to the baby. However, benefit outweighs the risk. And morbid obesity is listed as a contraindication, and truly that is more for smaller machines or like older machines. Nowadays, these can tolerate a lot more weight. But our visualization may not be that great either because they're trying to go through so much tissue. CT scans can be used with or without contrast. So one of the important things to know is, am I giving contrast with this? And then, are they allergic to shellfish or iodine? And then my follow-up question is, what happens when you have these? Okay. You guys have probably seen this already in nursing school, taking care of patients, where you go into their chart and they say, I'm allergic to Tylenol, just for example. And you say, what happens when you have Tylenol? And they say, my stomach hurts. Cool. That is not an allergic reaction, that's a side effect. So sometimes things are in the chart saying it's an allergy when it's really not. So whenever you see an allergy, ask the patient what happens when this happens. Because depending on the severity of it, they may treat the patient with some Benadryl so they can use the contrast depending on what they need to see. Additionally, we have to care very, very much about the kidneys. Okay, I know we're talking about lungs here, but contrast is really hard on the kidneys. Contrast and metformin can cause lactic acidosis and can fry your kidneys. So we have to be careful. Contrast can be given orally or IV. Orally, they're NPO, they drink this drink. Usually that's more of the inpatient thing. IV, it's exactly what it sounds like. They push some contrast through you. Important teaching point, that them pushing that contrast makes patients feel like they just peed themselves. They didn't, but it's important to let them know you're going to feel a flushing feeling and it feels like you peed, but I promise you didn't. So, yeah. And there's many, many kinds of CTs. There's CTPEs, there's CT angios, there's just a CT chest. It truly depends on where you're going, but okay. More imaging, MRIs. I will be completely honest with you guys. In terms of respiratory diagnostics, unless we're staging cancers, we don't really do MRIs for respiratory stuff, but we're talking about imaging, so we're throwing it in here. MRIs give you the most detailed, insane images of something. All the tissue, all the vasculature, it's insane how much you can actually see. They use magnets and radio frequency to collect these. MRIs take a really long time. They have to lay still for like 45 minutes at a time. It's incredibly loud and very narrow. So for somebody who is claustrophobic or very, very anxious, this can be very difficult. MRIs also can use contrast depending on what they're looking for. Honestly, in practice, you're going to see MRIs more for orthopedics or neuro or spine. Well, spine is neuro than anything else. Again, not so much with the respiratory, but again, anything is possible. We also have to be concerned about implants. So certain metals will be okay, but certain metal implants are not. So I encourage you, when you get to clinical, ask to see their MRI checklist. And it gives you a really big breakdown of the questions that they ask and the things that they're looking for. Because again, this is a magnet. It will rip and fling, and I've seen wheelchairs get thrown up against it because it grabs it. That magnet is always on. Certain tattoos will have metal. The ink has metal in it, and it will rip the tattoo like out of the skin. It's gnarly. So we really have to be careful when we're dealing with metal. No piercings. It will rip that out too. All that jewelry. Again, it's really loud. So earplugs may be helpful, even some medication, okay? Especially if they're stressed out about it or they have a history of claustrophobia. Let's see if we can give them a little something. Ask the provider, hey, can we give them a little lorazepam to get them through this? Because if they don't lay still, they're not going to get the imaging. They do have open MRIs now, which are a lot bigger and not as intense as like this little tunnel that patients have to go through. But that is, again, facility dependent, and not everybody has that. Also, MRIs are really expensive. So there really has to be a good indication for it as well. Any questions so far? You guys don't talk much. It's okay. It's the first day. All right. The last imaging that we're going to talk about is fluoroscopy. You might have actually heard this term flung around if you work in healthcare or in clinical. Like, yeah, they need to go have this done under fluoro. This is what they're talking about. There's a video here if you copy the link and look at it. But what it is, it's live X-ray. So the most common things that we put in under fluoro is an NG tube, or they'll do a lumbar puncture. And what it does is it shows the movement so they know what they're going into. So somebody that might have some like obstructions in their throat but need the NG tube will get it done under fluoro so they can put the NG tube in and see where they're going. This is done in interventional radiology. Has minimal, I mean, it's got radiation exposure-ish because it's an X-ray of sorts. But truly it's used so they can insert things without hurting someone because they don't know what's going on. It helps facilitate invasive procedures. Again, the two big things you'll see this done with are NG tubes or lumbar punctures, and then some barium swallow studies, which we talk about in week like 8 or 9, just so they can see what's going on. And it's very, very cool. All right. Polling question time. Don't overthink this. Ooh. All right. A few more seconds. I think everybody who answered did. Least invasive, that is going to be your pulse ox. Yeah, the X-ray is non-invasive in the fact they don't have to do anything, but radiation is invasive and more damaging compared to a pulse ox. So, awesome. All right, so the next thing we're going to dive into is chest tubes, and that seems to be like one of the harder things that we kind of dive into this week. So we're going to go ahead and take a break a few minutes early just to aid in that. It is 11:56. Let's actually, I need to let my dog out, so let's take a little bit longer of a break and come back at 12:15. Okay, grab a snack, be energized. Where am I going?
Understand every life must end. As we sit alone, I know someday we must go on. Oh, I'm a lucky man to count on both hands the ones I love. Some folks just have fun, yeah, others they got none. much in this world to make me believe. Stay with me, oh, for all I see. Did I say that I need you? Did I say that I want you? Or if I think I'm a fool, you see, no one knows this more than me. As I come clean, I wonder every day as I look upon your face. Everything you gave and nothing you would take on. Nothing you would take. Everything you gave. Did I say that I need you? Oh, did I say that I want you? Or if I did, I'm a fool, you see. No one knows this more than me. I come cleaner. Nothing you would take, everything you gave. Over till I die, get you on the other side. Finding my way back to sanity again. Do I really know what I'm gonna do when I get there? And take a breath and hold on tight. Spin around one more time and gracefully fall back to the arms of grace. 'Cause I'm hiding on every word you're saying. Even if you don't wanna speak tonight, that's alright, alright with me. 'Cause I want nothing more than stare outside heaven's door and listen to your breathing. It's where I wanna be, yeah. All I can do is keep breathing. All we can do is keep breathing.
All right, let's bring it on back here. Thank you for those extra few minutes so my dog doesn't get too squirrely. Hopefully you guys caught on to the theme of the music today. I like to do themes as much as I can, with the exception of like our obesity unit, because it's kind of hard to find songs for that.
I just wanted to say I really enjoyed the Pink Floyd because I just went to a tribute to them and it was amazing.
I have high five to you. You're now one of my favorites because they're one of my favorite bands. So
I'm obsessed. So
yeah, so next week we also do respiratory. So if there are breathing or oxygen or whatever songs that fit, shoot them my way, as long as they're school appropriate. Same thing with the other units that we do, because I got 4 weeks of cardiac, so I tend to run out of stuff and you hear the same stuff over and over again, but whatever works. All right, so chest tubes. Chest tubes seem to be the bane of most on this first unit. And I'm going to hopefully break this down a little bit more in a way that will really make sense. The true thing to understanding chest tubes is to understand the adjectives that are being used to describe things. Okay, so chest tubes will drain either fluid or air from the pleural space. Okay, they're in the pleura. The little nubble guy goes right into there and will help evacuate whatever is causing the issue in the lungs. When a chest tube is set to water seal, what that means is it allows stuff to leave but not come back in. So this down here, that's what we're talking about. This prevents the water and stuff that they put in there, prevents the air or fluid from going back in. Titling is an expected finding of this water. And by titling, I mean like movement, okay? It should rise and fall like waves do in the water. And that happens when we breathe. When we take a deep breath in or a deep breath out, we're going to see that titling occur. We want titling to occur, okay? It should happen. If it doesn't, we either have a blockage or it's kinked, or best case scenario, the lung has re-expanded and we don't need it anymore, in which case we have other findings. But titling should be happening. With titling may also, the other part of titling is bubbling, okay? So bubbling tells us that there is an air leak, all right? The air leak will either be small, so I'll have a couple bubbles here and there, moderate, so some more intermittent bubbling, or frequent, which means I got a big old air leak and that's an issue. So depending on how bad the air leak is, there's little numbers down here on the side, which we'll see in a video that will show you how big the air leak is. So continuous bubbling is not good. That means that there's a big air leak between the drain and the patient. So when we have bubbling, we want to check to see if something got disconnected or if it's loose or something needs to be reinforced. With big bubble, with big air leaks, we want to notify the provider. With smaller ones, we're going to continue to monitor. So truly, when they're talking about bubbling, what adjective are they using to describe what's going on? All right. When chest tubes are inserted, they're inserted for a couple different reasons. Either a collapsed lung, bleeding in the lung, like a hemothorax, post-op wise to help with removal of stuff, or if we have a buildup of pleural fluid, or an empyema, which is an infection. It's a big old infectious sac, okay? I had a motorcycle accident patient that I cared for that had 3 chest tubes. Like, it truly just depends. And then I've had, people that had something done, a surgical, a CT, cardiothoracic surgery, they had 1 chest tube. So it truly depends. If it is a planned, like we need to put this in, if it's in surgery, they're already sedated. But if it's before they're coming in, we need to get this in quickly. We need to either sedate them or at bare minimum, give them some pain medication, because this is not pleasant. They slice the skin open and the fascia and the muscle, the intercostal tissue, and they shove that in there. There is a lot of inflammatory pain that goes along with chest tubes. So narcotics can help to an extent, but inflammatory pain is usually best served with anti-inflammatories and then some muscle relaxers to help relax that tissue around there. All right. So beforehand, let's make sure that they are either sedated or medicated for pain. During wise, let's look at those vital signs. If somebody is having a chest tube done, again, it's going to hurt. What expected findings of vital signs would I expect in somebody who's having this done?
Elevated vital signs, so like high blood pressure, high heart rate, because they're probably nervous or going through pain.
Yeah.
Respiratory.
Yep. So I expect high respiration rate, high pulse, high blood pressure, all the things we would associate with pain. If they're sedated, they might be elevated as well. Hopefully they're not feeling too much, but it truly depends. Afterwards, we're still looking at those vital signs. We are also making sure that the patient is coughing and deep breathing. Yes, they have a tube to help drain stuff. However, again, it hurts. When something hurts in your chest, you tend not to take really big deep breaths because it hurts. What potential complication are we concerned about if they're not taking deep breaths?
Atelectasis.
Atelectasis. And atelectasis leads to pneumonia, and that leads to other post-op complications. So we really want to make sure that they are doing their coughing and deep breathing to get the most that they can. We have to prevent this. They're not going to want to because it hurts, and I get that, but it's something that needs to be done to prevent them from getting even worse. And here's a nice little image. You got your chest tube. It's covered with a nice little bandage, and it will leak out and do what it needs to do. With chest tubes, there are potential complications. And again, those are those air leaks. And we see that with continuous bubbling, or something happened to the tubing, or the dressing is not secure. Let's look, identify, and confirm what's going on here. Furthermore, just because there is an air leak doesn't mean we're necessarily going to discontinue that chest tube. They may reinforce the dressing, or the provider may insert it further or do something else. But other potential complications with chest tubes is a pneumothorax, a tension pneumothorax, which is a buildup of pressure. Yeah, we put chest tubes in to heal tension pneumos. We can cause them too. And usually it's caused because something got kinked or clamped that wasn't supposed to be. So I know you guys had some experience with chest tubes in lab and stuff. We don't strip drains with chest tube drains because that stripping can cause a backflow of pressure, which can then cause that tension pneumo. Or if we clamp it when we're not supposed to, that can also cause that. Or it gets rolled over on, or something happens to it. So we just have to be on the lookout for that. One thing that you need to understand too, when a chest tube is inserted, especially around the insertion site, crepitus can form. What do I mean by crepitus?
It ends up in the tissues.
Yeah, so subcutaneous emphysema, like feels like Rice Krispies when you push down on it. At the insertion site, when it's first inserted, I expect that because I'm shoving something into a new space and air is going to get in, but it's going to go away. However, if it is hours later and the subcutaneous, the crepitus has spread, that's more concerning. Something else is going on here. So when I'm inserting something, I do expect a little bit of crepitus around the site, but hours later, days later, I don't expect that anymore. It should have resolved. The air should have escaped by then. So all patients that have a chest tube need certain things in their room. They need an occlusive dressing. They need a container of sterile water, and they need a hemostat. So anytime you see a patient coming up from the ER, OR, ICU with a chest tube, those supplies need to be in that patient's room. In the event that the patient accidentally removes their chest tube, like it gets pulled out or something like that, the tip that came out of the patient goes into the sterile water. We need to cover that hole, all right? We put that occlusive dressing on there. We tape it on 3 sides. Doesn't matter what 3 sides, but we cover it on 3 sides to allow air to still escape. And then we notify the provider. I know that sounds backwards, but we are wasting valuable time. We need to cover that hole because further complications can happen. So into the water, cover it up, notify the provider. If it is a scheduled removal, like they planned it, they did their x-rays, they figured out, okay, we're not draining anything anymore, let's go ahead and remove this. We as nurses need to medicate the patient beforehand, give them a little pain medication to help with this, and then they will remove the sutures because they're sewn in. The patient bears down, aka they strain like they have to poop, and they'll pull it right out. Afterwards, we want to make sure that a nice airtight dressing is applied to the covering it. They'll get a chest x-ray to see how their lung is expanding the way that it should, and then we'll watch for any type of drainage that might be coming off of there. With removal of chest tubes, this can be done by the thoracic surgeon, it could be done by whatever surgeon that did it, a trained nurse practitioner, a PA, those are the ones that will do the removals of this, the provider, we'll use that term. Let me see here. I forgot to show this, so let me pull this up real quick. Oops. All right, so here's a little bit more of a visual of the titling.
As with any chest drainage system, the drain must be placed below the level of the patient's chest and kept in an upright position to maximize drainage efficiency. All patient tubes and suction connections should be routinely checked to ensure proper leak-proof operation and chest tube patency. Depending upon your hospital's preferred sampling technique, samples of drainage fluid can be taken directly from the patient tube by forming a temporary dependent loop and inserting a 20-gauge or smaller needle with syringe at a shallow angle. On selected models, samples can be taken directly from the needleless Lure-Lock sampling port located on the patient tube connector. A water seal is a simple one-way valve which allows air to exit the chest and prevents air from returning to the patient under normal conditions. It's also a very useful diagnostic tool as it can show even the smallest trends of an air leak, as well as changes in intrathoracic pressure. Assessing patient air leaks is easy with Atrium's Blue Tint Water and Air Leak Monitor. Continuous bubbling observed in the water seal will confirm a persistent air leak in either the patient's thoracic cavity or possible tube connections. Intermittent bubbling with gentle float ball oscillation will confirm the presence of an intermittent air leak. And no bubbling with minimal float ball oscillation at the bottom of the water seal indicates that no air leak is present. Bubbling from right to left in the air leak monitor must be present to confirm an active air leak. When monitoring a chest drainage system, it's important to maintain constant gentle suction control bubbling and to periodically check and adjust the water levels in both the suction control chamber and water seal during system operation as required. In the event of an accidental knockover, place the drain in an upright position immediately and check for interchamber spillover and correct fluid levels. Both suction control and water seal fluid levels may be adjusted as necessary.
All right. So hopefully that kind of makes a little bit more sense in terms of like continuous versus intermittent, okay? Intermittent could happen with coughing even, like pressure builds up and like air can like get out. So we have to really just take a look and look at our patient and figure out what's going on here. But continuous bubbling is an issue. We do eyes and O's with chest tubes too, so making sure that we're monitoring and seeing how much output we're having. We draw a line, our initials, the time, and the number that we're at. If all of a sudden you have a massive increase in output or a total like stoppage, that can be concerning, and that is something that we would want to notify them. So any change in consistency, color, like very rapidly, or amount, something else could be happening, like we could be hemorrhaging, or if it all of a sudden stopped, like we were getting 200 every shift and now I have 0, I have to be concerned that maybe something got, we're getting a occlusion somewhere. And if there's a buildup, then we're going to see some increase in pressure. So there is an atrium video on YouTube that will like show you from insertion to removal. It's very cool. It's like 15 minutes long, so we don't show it in class, but it's definitely helpful if you want to see like the whole procedure and how it goes, because you don't always get to see that. So, all right. What questions do we have on chest tubes? All right, so then I have a question for you on chest tubes. There's your polling question.
I have a quick question, just really quick. I just thought of it. Remind me what is important when there is an accidental disconnection. What's important to keep at the bedside?
Sterile water,
Okay.
hemostats, and an occlusive dressing. So like the Vaseline gauze.
Okay, good deal. Thank you.
Yeah, my old unit, we had a lot of CT surge patients, and anybody that came up with a chest tube, we had a little bag that would hang at the top of their bed with all that stuff in there in case something happened. All right.
Just to clarify real fast, what there would be waves if it was normal, and then would there be bubbling in the little chamber?
There might be sometimes with cough, but it would be like a bubble here, a bubble there, something like that. Bubbles indicate an air leak. Random or small amounts of bubbling means small air leak. Intermittent means it's probably like a middle of the road air leak. Do we do a lot for it? Not so much, we just monitor. But continuous bubbling means it's a big air leak.
Okay.
So really it's just about identifying what word they're talking about.
Okay. What would that little metal ball be doing in a normal situation?
Chilling.
Just chilling.
It'll
Okay.
it'll rise and fall with like inspiration and stuff. But if there's an air leak, it'll go up, 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 up.
Okay. Thank you. That made me laugh.
What, chilling? It's just hanging out. Okay, so the chest tube is going to remove air and fluid from the pleural space. The pericardial space is the area around the heart, and that's a whole different procedure. And then we don't want to add anything to that. So, all right. Okay. So let's talk about respiratory management here. All right. So as nurses, we have to do things from least invasive to most invasive. And I don't want you to look at something like breathing exercises as like, oh, that's so granola and so hippy dippy. It truly is a very good method to restart our breathing cycle, okay? We want to encourage breathing exercises when somebody is under stress or they can't breathe, or if they're in pain. We can use breathing exercises for a lot of different things. The purpose of it is to breathe slowly and rhythmically to get back on cycle, and it's distracting, but it helps calm them down and breathe effectively. So the whole point of breathing exercises is to have them breathe in through their nose and out through their mouth. By exhaling through their mouth, it's going to prolong that exhalation time and allow them to slowly push off that CO2 in a calm manner, okay? So I always tell the patients, smell the flowers, blow out the birthday candles, and just repeating that. They may need to be in a tripod positioning, which will help with maximum lung expansion, but it truly is about inhaling and exhaling, and it helps center them, it helps focus, it helps reboot them how they're breathing. So don't poo-poo the breathing exercises. Oxygen therapy is another form of treatment that we can give someone. First and foremost, oxygen is a medication, so we do need an order for it. Most places, most patients have standing orders for you to apply oxygen. They don't want you to wait. If they're at 75%, they're working to breathe. We can't say, oh no, we have to wait for an order. You have the order, okay? We have to treat them. If it's not in the chart, it'll get there, okay? So with oxygen therapy, what you're really doing is giving oxygen, but at a higher concentration than what we're breathing in right now at room air. So it is a high concentration of oxygen, and then we adjust the liters per minute with how much flow they're getting. So the oxygen that they're getting through like a nasal cannula or a mask is at a higher concentration than if we were just breathing normally. It's important to know that hypoxemia or low blood oxygen can lead to hypoxia, which will cause cell death, which leads to a whole lot of other problems. So when we're giving oxygen, we want to give it at the lowest flow possible to correct the problem. We don't want to jump on 15 liters unless it's super, super bad. If they're at 88% and they just need a little tickle in their nose, give them a little tickle in their nose, not a big old honking mask, okay? So we want to make sure that we're giving the right amount of oxygen, lowest amount possible, with the right administration, so the right modality, nasal cannula, mask, whatever it may be. If they're ventilated, watching their ventilator settings. The whole goal is to, yes, get them breathing, but not to get them to do it on their own. So we always want to get them off of it. Additionally, with oxygen, we have to be very careful about the skin. Oxygen is very drying and can cause a lot of issues with bloody noses, especially with more flow and more concentration. So giving somebody like 6 liters of oxygen might be necessary, but we need to add a little water to help humidify and keep moisture within. Otherwise, you're going to get cracks and bleeding, and it can be very uncomfortable. Additionally, the masks and the nasal cannulas are pressure. They put pressure behind the ears or on the face and can cause skin breakdown. So if they're wearing oxygen cannulas for long periods of time, they have the little foam pieces that can go on there to prevent pressure ulcers from forming. I've seen them on the ears and they can be really bad and we forget about them. Also, oral hygiene. I can't tell you why, but people in the hospital seem to not brush their teeth like they do at home. I don't understand it. Their little cup and their little toothbrush will sit there their 3-day stay. But if they're breathing and we're working on inhaling and exhaling, we got to get that gook out of their mouth. It's going to help open up their airway too and make them feel better. So oral hygiene is important. So with oxygen therapy, we use it with shortness of breath. If it was ordered by the provider, if their O2 levels are low or they're visually cyanotic. We have to be careful that we don't give too much oxygen. We don't want to take away their their ability to breathe on their own, which can happen with our COPD patients. And also, oxygen is flammable. So we have to be cognizant of that. No smoking. I don't know if any of you guys have been to the casino. I don't know if there's casinos in Utah. I'm going to guess that there are. But like for whatever reason, at least here in Milwaukee, like the little old ladies, and it might be men too, sit there with their oxygen on and they're smoking away because it's Indian grounds and they can smoke inside. And I just sit there and I shake my head. I'm like, we're all going to die. Like they're not careful. Also, the ointments and things that you use can be flammable as well. So we want to prevent using any type of oil-based lubricants because it can catch a spark and then poof, we don't want that to happen. So safety concerns there. In terms of oxygen delivery devices, some of these will look familiar, some of them may not. Nasal cannula, that's our gold standard, right? Gives us up to 6 liters of oxygen through the nasal cannula. What are some potential issues with nasal cannulas?
Dislodging.
Okay, either accidental or on purpose. People like to just like take them out.
Possible skin breakdown.
Yeah. You know what the
Pressure injuries and drying mucosa.
Okay. The biggest
Trip hazard.
Yes, absolutely. One of the things that I've noticed is people put it in upside down. They don't put it in right. So make sure the prongs are in properly, okay? Nasal cannulas are great because they allow for people to talk, to eat, just it's kind of out of the way. Whereas a mask is going to be more constricting. People might have issues with breathing, that sort of thing, and that they can be concerned with that. Simple face masks, we can give 5 to 8 liters. If you don't know, green tubing means that it's high flow tubing. So it can sustain a lot more oxygen flow liters per minute than clear tubing. That's what that means. Anybody know what this little funky thing is? Sorry, what this bad boy is?
A Venturi mask.
It is a Venturi mask. Has anybody seen one of these ever? Oh, good, because I never have. 10 years, I've never seen one. What's awesome about the Venturi mask is that there's these adjustable valves and will help give you the most precise flow and concentration of oxygen. So of all the delivery methods, aside from a ventilator, you can control the most with it. What circumstances did you guys see the Venturi mask? Do you remember?
COPD patient.
Okay. Yeah. So those little valves can change. Then you have your non-rebreather, which usually we see patients come into the ER with EMS. It has that bag attached, high flow, 10 to 15 liters that they're getting this on. Here, right here is a CPAP mask or a BiPAP mask and a CPAP machine, which we'll go into a little bit more. This is an example of a ventilator. Wherever you work, every ventilator is going to look completely different, depending on the make, the age, the model, what's going on. Some will have big screens, some will be a lot smaller. It really truly depends. And then you have an ET tube, which is the one that goes down the throat to connect to the ventilator. And then this is just another example of an oxygen flow system. So you've got your oxygen meters. There's some humidity. It may look different. Usually it's just something on the wall, but there we go. Okay. Good Lord. Incentive spirometry. This is one of the things that we probably teach the most as nurses. Anybody post-op is getting incentive spirometry. Its purpose is to prevent atelectasis. I tell my patients, I'm exercising your lungs while you're stuck in bed so you don't get pneumonia and you can get out of here quicker. The most important thing with incentive spirometry is proper education. because 9 times out of 10, they're not doing it correctly because we forget. So with the incentive spirometer, when they inhale, this bottom white piece is going to raise up to a goal. The order will say what the goal is. And then this piece on this side will either rise and fall based off of how they're holding it and maintaining it, okay? The biggest issue people have with incentive spirometry is that they don't know if they should blow or if they should suck. This looks like a straw. And what do we do with a straw? We suck, we inhale. So if they are confused, just tell them to treat it like they would a straw drinking a milkshake. The whole purpose is to exercise their lungs and inhale in a slow, controlled manner repeatedly, 10 times an hour while awake. So the goal is to have them sit upright, using their diaphragm, like controlled breathing, put the piece into their mouth, and they're going to inhale. They're going to hold it, and then they're going to exhale. And we want them to cough after they're done, but to do this every hour while they're awake to prevent the atelectasis from happening. Doesn't matter if what they're having done post-op wise, every patient should have one of these for the most part. Okay. My favorite is when I see them at like rummage sales or at Goodwill. That's the greatest. Okay, I don't have a polling question here, so we're going to go to the next one. Nebulizers. So these little guys, they come in 2 different ways. They can either be a little handheld one that connects the oxygen on a wall, or we have a nice little machine where they can do the same thing. The nebulizer is used to give medication to a patient almost, I can't say always, very frequently due to asthma or some type of breathing issue. The most common medications that we give in a nebulizer is either albuterol, which is a bronchodilator, or something called a duo-neb, which is albuterol and ipratropium bromide. Duo-neb, there's 2 medicines. What happens is they open up the little ampule, plastic ampule, they pour it into this little container, either one, they turn it on, either the oxygen or the machine, and a mist magically appears. You're inhaling that mist, you're inhaling that medication. Goes for about 7 to 10 minutes, helps open up that airways. Important nursing consideration, giving them all their medication, rinsing out that container when they're done, and then making sure the patient knows like, hey, when this stops smoking, you're good to go. Let me know so I can turn it off. Respiratory therapist is great with helping with these, but you may have to administer these as well, especially if they can do it on their own. You want to make sure before and after you give medications or therapies, you are assessing before and after, because you want to know, A, why am I giving this? And B, then was it effective, right? These little machines are really common for people at home, either with COPD or asthma, because it just plugs in. It doesn't require an oxygen tank, whereas this tubing and one would. So, all right. Now, non-invasive positive pressure ventilation. That's a whole lot of words to be talking about CPAP and BiPAP. So what it means is that we're going to open up our airway to promote gas exchange, either through a CPAP or a BiPAP. CPAP is usually used for our sleep apnea patients, and typically it's just into the nose or over the nose, whereas BiPAP is bi-level, so mouth and nose, creating a big seal and is more invasive. They both do very similar things, but typically our BiPAP patients are a little bit worse off than a CPAP, okay? So CPAP machines, people have at home, they go through a sleep study, they've been determined that they have sleep apnea, which means they are not breathing. They will stop breathing multiple times per night. The number one way somebody gets diagnosed with sleep apnea is their partner, because their partner's aware that like they stop breathing like 10 times an hour. So They'll get the sleep study done. They're like, oh yeah, you need this. They'll get put on the mask and they have to wear it every night when they're sleeping. There are compliance issues with CPAP machines because they can be noisy. Partners might not like it. The patient doesn't like wearing it. It might interfere with intimate time in the bedroom. There's numbers of reasons why people don't do it, but it's saving their life. Being from Wisconsin, I don't know how old most of you guys are, but Reggie White was this amazing football player who played for the Green Bay Packers and the Eagles in the 90s. He died of sleep apnea because he just stopped breathing in his sleep. So we go over sleep apnea a little bit more next week. The bi-level or the BiPAP can also be used for severe cases of sleep apnea or with our COPD patients, or it can also be used prior to being ventilated because it forces everything open. Some people don't want a tube shoved down their throat, but they're okay with a mask forcing things open. So it can be a life-sustaining measure. Okay. I'm gonna skip this for now. All right, ventilators. Ventilators that's life support, okay? It will help with, it's breathing for the patient. It might be for reasons because of respiratory failure. The airway is failing. There's a trauma. They can't protect their own airway, meaning it's starting to collapse on its own. They can't breathe well. There's an illness. No matter what. And then there's the big scary thing is we're giving meds, we're giving oxygen, we're doing everything we can, but they're not getting any better. We need to get them intubated so they're getting 100% oxygen and we don't watch their pulse ox drip too low. Again, this is life support. If they are on a ventilator, they will be intubated. Okay, so they get this ET tube that will go into the mouth through the vocal cords down to the carina. This can be placed by either a doctor, a trained CRNA, or an anesthesiologist. Respiratory therapist can do this as well, or trained nurses like flight nurses or something along those lines. Our job as a nurse is to, if they need intubation, gathering the correct supplies and helping with medications and positioning and things along those lines. When someone is intubated, our goal is to get them off the ventilator as soon as possible. So we want to wean them as soon as we can to see how they're tolerating it and getting it out of there. A person should not be intubated for more than 14 days. If they require, like we cannot get them off the ventilator, they need to get a tracheostomy placed instead. So these ET tubes are not meant for long-term use. We have to go surgical route then instead. We can also place ET tubes in the nose. They can do a naso insertion, which isn't as great, but they can do it. There's even been some orbital intubations where they've went in through the eye. The oral route is preferred, less infection, and we can use a bigger tube to get them intubated. The bigger the tube, the more air, the better they're going to be breathing. Basically what they'll do is they'll open up the mouth, they'll use a laryngoscope, which is like a camera, to kind of visualize and see things. They'll pass the tube through, they'll inflate the cuff, which is like a little balloon to keep it in place. And then they put a little monitor on it and it turns a color. That's how they know it's a CO2 detector. They know that they're in the right place. We'll confirm with X-ray. The bad things that can happen with ET tubes are usually occlusions. So we need to make sure that we're suctioning properly. We're maintaining skin integrity. We can adjust the tape. We can move this tube from side to side and making sure that the patient stays hydrated. Why do we care about hydration status?
Is it the mucous membranes?
Okay. What do
And they're
fluids?
just, oh, sorry. No, you go. You go.
Oh, well, I was just gonna say, like, how are they able to necessarily drink water when they have this tube in?
Okay, so we can give fluids through either a PEG tube or an IV so they can get hydrated. What does fluid do to secretions?
Thins them out.
It thins them out, which makes suctioning easier. So hydration status is really important because if we have thick gook, it's harder to get out and it can cause issues for the patients versus if they're hydrated, it'll thin the secretions and make it easier to remove. Again, ET tubes and ventilators are critical care. You may never, ever see one, or you might deal with them every day. Our purpose now is just to kind of introduce you. This is what they're used for. This is what safety concerns we would have. It's a basic. If you work in an ICU setting and with ventilators, you will get specialized, intense training on how to take care of that machine and somebody on the vent. If the person cannot, the ET tube is, we can't get them off, they'll do the trach. So they're going to create a surgical incision, a little stoma, and then that's where the trach gets placed. It can either be forever or it could just be until they're good and on their own. So review your suctioning technique from last semester. I know you had a check off on it. Just be comfortable, okay? I want to hyperoxygenate. I want to make sure that I don't do this and not do that, and what's sterile and what's not. You have your dirty hand and your clean hand and all that good stuff. If somebody is ventilated, okay, we need to make sure that we are assessing their respiratory status at least every 2 hours. They're sick. This is an issue. Just because they're vented doesn't mean we don't take care of them, okay? So we want to make sure that they're suctioned, that they're getting enough oxygen, they're on a monitor, and we make sure that we reposition, okay? Additionally, these patients, because the end goal is to get them off, we're watching ABGs, we're watching their oxygen level, making sure that they're going in the right direction. And if they're not, we have to notify someone. Also, I don't know if you guys know this or not, so I don't mean to talk down to you in any way, shape, or form, but not everybody that's ventilated is unconscious. They may be awake with a tube down their throat. So we have to make sure that we're still communicating with them in a way that they understand. So I'm not saying, like, don't go really slow or talk really loud. It's because they're not deaf. They just can't talk because there's a tube in their throat. So make sure that the communication methods match your patient. Writing things out, texting things, a whiteboard, a picture board, whatever works. But again, not everybody that has a tube down their throat is going to be unconscious or even paralyzed. They might be walking down the hallway on a ventilator. They're trying to do more with less paralytics and they have better outcomes when people are up and moving, even if they're intubated, than being unconscious. That being said, some will be. They'll be sedated, either with some type of conscious sedation like fentanyl and propofol, or our paralytics like our vecuronium. Please do not administer vecuronium without an ET tube in place because everything paralyzes. Everything. Okay. Again, that's advanced in terms of specialized ACLS, that sort of thing that you'll get into once you're working on the unit. Your true concern is understanding what's good, what's bad, what do I need to do to care for them, and caring for the patient as a whole. Patients who are ventilated can still go through complications, trauma with extubation. That tube is forced down the throat, causing inflammation and whatnot. When we pull that tube out, that inflammation remains. They will probably have a very sore throat, to which we have to say, you got to be quiet, no talking for you, sorry. We want to rest their vocal cords. Humidity will be helpful. We have to be on the lookout for potential re-intubation. Is their airway maintaining? Are they having any issues with that? If they're still tubed, they're at high risk for ventilator associated pneumonia. So how do we prevent that? We keep the head of the bed slightly elevated, semi-Fowlers. Peptic ulcer disease prophylaxis. This is our PPIs, our proton pump inhibitors, which you're comfortable with. We don't talk about GERD for a few weeks, but that acid can flow backwards, causing ulcers and potential aspiration, and puts them at risk for pneumonia. Also, they're pretty much bedbound, so DVT prophylaxis is important as well. We don't want a DVT to become a PE, and then we have to deal with a PE on top of being tubed. And then our oral care. Oral care with chlorhexidine. Just because there's a tube in their mouth does not mean they don't get their teeth brushed. So we need to make sure we're swabbing things out and taking care of that as well. Questions on tubes? I don't have that. Okay, so as I mentioned, we have to be on the lookout for inflamed vocal cords. There is a high risk of needing to be re-intubated. If they need to be re-intubated, we have to use an even smaller tube than we did before because it's all inflamed and puffy. We have to watch their oxygen levels after they're extubated and their ABGs, because the ABG is that most accurate assessment piece that we have. And additionally, we need to watch for what they call post-ICU syndrome or ICU psychosis. Hospitals are meant to, you get better, but it's not a healing environment. There's a lot of beeping, a lot of noise, a lot of stimulation that can cause people to go cuckoo for Cocoa Puffs by no fault of their own. It's just too much and your brain just, so we have to watch for any type of overstimulation, issues with the patient, delirium, that sort of thing. It is very, very real. Okay. Yeah. Watch out for accidental removal. Sometimes patients may have softer strains on if they're trying to pull at that tube all the time, but that's a whole another thing. Okay, so now we're going to talk about some of the not so good stuff with nursing, okay? And we're going to talk about some of the legal things. It is important for every person, not just your patients, yourself, your classmates, whoever you come in contact with, to understand what they want in life or in an urgent situation, okay? An advance directive is a written document that you can make today that says, I want this, 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 and this if this were to happen to me, but don't do this, this, and this. All right. You can create them at any time. I'm going to tell you, most people don't have advance directives until they're older because they think, oh, nothing bad can happen to me. My husband died at 35. 35. If we had advance directives in place, it may have changed things. Who knows? But it's important you can do them now. I remember when I had my oldest, the OB was like, do you have advance directives? I'm like, I'm 25 years old. What do I need advance directives for? It's like, well, you never know what can happen. And then your needs are able to be known. So it's basically, if you can't let your needs be known, you have it in writing. Okay. A do not resuscitate order is a form of advance directives. This is a medical order that two doctors have to sign off on, that you don't want CPR in the event of a cardiac arrest. There is also do not intubate, or DNI, which means don't put a tube down my throat. So somebody could be a DNI, but not a DNR. So they're fine with doing CPR, just don't put a tube down my throat. And then some people are both. There's also durable power attorney of healthcare, which is a term that gets thrown around a lot. This is a legal document where somebody is saying this person can make these choices for me if I cannot. Sometimes family members will say, well, I'm the power of attorney. Your person can totally make their needs be known. It is not activated, it is not. So we have to find out if it's an activated power of attorney or just, I could say, oh yeah, my best friend is my power of attorney. Well, unless I can't make my needs be known and it's activated, it's just words, if that makes sense. A living will has to do with treatment preferences. So it is similar to advanced directives. And it usually goes in line with durable power of attorney. It is important, guys, that when you are, if you have to pick a power of attorney, that there's somebody who will follow through with your wishes. And I say that because not everybody is capable of making those decisions. And that power of attorney has a lot of power. You might not want this, but they do. So do they have the right ability to make these decisions? Or will they say what you want? I'm going to guess a good number of you guys, probably half, are organ donors. You got your little orange sticker on the back, or you registered through the organ donation thing, which high five, donate life. Your next of kin or your durable power of attorney could say, no, I don't want to donate the organs. And they have the right to do so. So what I'm saying is make sure that that person will actually do what you want, or can make those tough decisions. A few years ago, my grandma had a stroke and I had to make decisions. She's fine, she's okay. But I had to make decisions, and even everything I know, all my degrees, all my experience, I sat there and I was like, I don't freaking know. Like it's somebody I love. What if I make the wrong choice? So it can be a very stressful time. If you don't have your end of life preferences in order, they go to your next of kin. So your family member could be making these choices. Depending on your living situation, it may be different. So your next of kin goes your legal spouse. Okay. If you are not married, it could be your adult children. And if you don't have a legal spouse or adult children, then it's your parents, which may or may not be a good thing for some people. And then it kind of just trickles on from there, depending on what you have. With healthcare too, it is important to understand that patients have the right to refuse at any time. They can say, no, I don't want that. What we do as providers is to say, I understand. You could say, tell me more about these feelings, or to tell me why. Educate, ask again. If they still refuse, we're good to go. We can't just take it at face value and be like, no, I don't want that. Okay, fine. We have to do a little bit more. We have to try more than once. But unless a person is like a ward of the state, we have to respect their right to refuse treatment or medications or however we want to go. Additionally, as a nurse, we are advocates. We have to advocate for our patient. If we don't like something that we see, a family dynamic, cares that are going on, therapies, we have to speak out. Most facilities have an ethics committee, or we can go to case management or social work to let our needs be known. If you are witnessing something that makes you uncomfortable, say something for your patient. It's like watching somebody commit a crime, but then like, oh, I don't want a narc, so I'm not going to say anything. It's the same thing. We have to be our voice for our patients when our patients cannot be. And that is my TED Talk. So my polling question is one that you cannot get wrong. Just out of curiosity, do you know the Muffin Man? No, who your next of kin would be? Most of you, it's probably going to be your spouse, but it might not be.
Kind of a question about that. So like if your next of kin is your parents, if they disagree on your care, which one would take priority?
They would get more people involved. So if mom and dad can't agree with what to do with you, you'd be like, or the patient, you'd be like, all right, we need to get somebody else involved because we have to come to a conclusion. Yeah. You can see how it can get real muddy, especially if the parents are divorced and they don't like each other.
Mm-hmm. Exactly.
I've seen people, yeah, I've seen some icky fights with families or exes. I had a patient who they were no longer married, but the ex was still their power of attorney. That could get very, very dicey. All right, so good, as long as you are aware. And if you don't like who your next of kin would be, get those advance directives in place. Get something done so that way you don't have somebody making a decision for you that you would not want making that decision for you. Last but not least, we're going to talk about delegation. And this is it's a big thing for nurses, and we need to be able to do it, okay? Delegation isn't about just dumping something off that you don't want to do. It's about tasking out things so their care you're giving the best care to your patient as a team. Nursing is a team sport. It's not a one-on-one thing. You can't do everything yourself. And if you try to, it can be very, very dangerous. So it's important to understand what you can delegate to whom. So LPNs are, first and foremost, they are nurses. Do not get it twisted. Some LPNs will have way more experience than you could possibly have and know way more than you do. So please do not poo-poo someone because it says LPN or LVN versus an RN, all right? Their scope may be slightly different, but I guarantee you they know a lot. So LPNs they help a lot with medication administration, treatments, overseeing things, helping the RN. LPNs, they can start IVs with specialized treatment or training, but they can't give IV push meds. They can't do ADPI the way that we do, and they can't do initial teaching. They can reinforce teaching, but the initial teaching has to come from the RN, but the LPN could absolutely back it up. CNAs are awesome with helping with cares, with toileting, with feedings. It's important to know if there is a change in diet, like let's say we're changing the diet from pureed to mechanical soft. The very first feeding that is done, that needs to be done by the nurse because we're assessing that they can tolerate this diet or not tolerate. So once they get the go-ahead and they're good to go, the CNA can do all the feedings. But anytime it's a brand new diet or a change in the consistency, we have to be there. With delegating, we have to be careful too. And like I said, we're not just dumping off things that we don't want to do. Yeah, getting a patient dressed can be a very long process. We've all been there, right? But do you know how much assessment stuff you can do while you're getting someone dressed? I can see their neurostatus. I can see their musculoskeletal system, how they're moving. I see their skin. They're talking to me. So I'm getting all that assessment data by getting somebody dressed. Yeah, it might take a little bit more time, but I'm getting to know them, building that bond, but I'm getting a lot of data. So don't always just pass things off because you don't want to do them. Additionally, asking for help or delegating is not a sign of weakness, it's a sign of strength. It means that you understand that you are split in 6-7 different directions depending on your patients, and you're trying to be there for everybody in the best possible way with our sickest patient or the one that needs us to do this task or whatever the case may be. So don't be afraid to ask for help is what I'm saying. Okay. Last thing that I have is just a couple more poll questions because I like practice questions and I know you guys do too. What do we want to do here? Oh, this is a good one. All right, a few more minutes or seconds here. So I feel like this is a really good question that you could pretend, not this question, obviously, you could see something like this on an exam. What is the priority? So of everything that's here, they're all important, but which one is the most important? Okay, because that's what priority means. And with this, there's a lot going on. I absolutely want to get a history. I absolutely will probably want a sputum culture. But first and foremost, I need vital signs and an oxygen level. That is ABCs. It is a potential threat to life based off of what is going on. I need that data first, and everything else can happen afterwards. When we're talking about priority, you have to think of Maslow, sorry, ABCs, threat to life. What can I do immediately to have information that I need that's going to dictate my plan of care? And those are the best way to look at priority questions. I don't want to do that one. I want to do this one. All right, so we're trying to wean what assessment parameter is most important. For weaning somebody off the ventilator, it is going to be that ABG level. The prior outcomes, they may or may not dictate anything, because we all know what happened before has no bearing on the future, right? It could, in terms of if it didn't work before, it might not work now, but stranger things have happened. ABG is the better answer here. Fluid intake is going to be important, but it has nothing to do with weaning somebody off of the ventilator. We would do it, but it's not going to dictate if they can come off or not, and neither would the EKG. So, last one, you guys' favorites, select all that apply. Okay. So thoracentesis, potential complications of a thoracentesis. So we think back to what we discussed, mediastinal shift. Could that happen? Yes. If we pull too much or we puncture something we're not supposed to and create a tension pneumo. Pneumothorax, absolutely that could happen. We're going into the lung area, no doubt. Bleeding, yep, we are poking that skin. Anytime we break the skin barrier, we're at risk for bleeding. Infection, same thing. So A, B, C, and D, absolutely. Arterial occlusion, would not. We are not going near arteries. We're not doing anything with the arteries, so that is not a potential complication. So, okay. What questions do you guys have about today, about the class, about anything? I don't know the meaning of life, but all right.
I just want to say I'm nervous for this class, but you seem to be very great. So I'm excited for like the attitude and just, yeah, I'm super excited now. I feel a lot better than I did going into it. So
good. Meds are just scary. It is, but you're going to learn things in class and then put them into practice. And when you're looking at test questions, first and foremost, we have to kind of forget what we see in practice because nurses don't always follow procedure. But what are you supposed to do? Or what would you do? So if your patient's in front of you and their pulse ox is this, and this is what's going on, what's the first thing that you're going to do? If you can relate that to real life scenarios, it's not as bad as it seems, but we'll get you there. The first 6 weeks are hard. I'm not going to pee on your shoes and tell you it's raining.
I feel like with being in nursing school too, I've worked med surg just like for 4.5 years as a tech, and I'm just learning the correct way to do things because I see things for 4.5 years and I'm like, I've never seen it done that way, or we've never done that. So it's been kind of cool to retrain myself, I guess.
Yes. And once you have your license, it's entirely up to you. We teach you NCLEX, perfect world, perfect scenario, everything how it should be. It may differ, but yeah, the first 6 weeks are hard. We got 2 weeks of respiratory and 4 weeks of cardiac. It really is, it's a rough start to the year. I'm not going to say it's smooth sailing after that, but I think we break it up pretty nicely, and practice questions are going to be your best friend. So do dynamic quizzes, create them in ATI, question books, however it goes. But if you can take a disease and you have the nursing process, what assessment findings would you expect? What would you have? Can you recognize like, crap, something is wrong or this isn't right? Diagnostics, what would we do? What are some expected levels that would say it's leading to this or that or how it's effective? And then planning. What are our goals? If somebody can't breathe, one of our goals is like, let's get them breathing again or not needing oxygen. How do we do that? Incentive spirometer, cough and deep breathe, ambulation, that sort of thing. And then we're big on teaching. What statement by the patient shows that they understand or would need further teaching? Those are really common questions in this course. So understanding how to teach someone, and if you can teach somebody about it, you understand it. So really, if you can understand those components of what we're talking about, you're going to be okay. How you get there, though, is going to be based off of what works for you. I was a big like note card person, or like when I did farm, I had crazy note cards. But I want to try to find something that'll help break things down for you guys. But some people are auditory, some people are visual, or they're hands-on. It really depends on what works for you guys, and we'll figure it out. But practice questions are going to be key, and reading the rationales as to why it's wrong. You learn a lot from the wrong answers. What word did I miss? What connection didn't I get there? And then you have that, oh crap, like you do when we meet for an exam afterwards. It's like, I knew that. So. All right then. Hopefully you guys have nothing else this Friday and you can go enjoy a little bit of Friday and put this first week behind you. If you have any questions, just reach out and let me know. Otherwise, I will see you guys next week, and this recording will be posted soon.
Thank you.
Thank you.
Thank you.
Thank you.
I have a quick question. Sorry. It was on one of the first poll questions. It was the one about the like increased compliance of the lungs. I missed which was the correct answer. Was it that it increased the work of breathing, or it was that the lungs were stretched?
The lungs were stretched. So
Okay.
increased compliance means that they're stretched too far. If it's an increased work of breathing, that's decreased compliance because they're hardened, so it takes more to breathe.
Okay. That does make sense. All right. Thank you so much.
No problem.